Welcome, everyone. Today, we are looking at the imaging and clinical management of the dancer's ankle. Our primary focus is understanding functional pathology and, most importantly, avoiding the over-medicalization of injuries that are often a normal byproduct of elite ballet training. We begin with standard radiography. Standard lateral views can often obscure key structures, like the os trigonum. Rotating the ankle to perfectly align the malleoli, we reveal these hidden structures. Plain films remain a crucial first step in deciphering posterior ankle pain. When we look at ultrasound, particularly regarding the flexor hallucis longus, or FHL, context is everything. Finding fluid around the FHL tendon is incredibly common and often completely normal in a working dancer. Ultrasound allows us to dynamically test the joint, but we must strictly correlate these findings with clinical pain to accurately diagnose true tenosynovitis. The MRI trap. This brings us to the pitfalls of MRI. It is very easy to fall into the MRI trap. Reports often return highlighting bone marrow edema, which sparks unnecessary panic for young dancers. Remember, an MRI is a static image. It cannot look at a dancer on point, nor can it evaluate their strength, technique, or workload. We must treat the functional limitations of the dancer, not just react to a scan. Diagnostic injections. By injecting a targeted local anesthetic, such as a small amount of celestone, we can instantly isolate the source of the pain. If the impingement is the issue, you will typically see the dancer regain about 15 degrees of plantar flexion once the block takes effect. However, we must use these sparingly, as local anesthetics and steroids are cytotoxic and can damage cartilage in large volumes. Impingement mechanics. Understanding impingement means knowing the mechanics. Anterior impingement usually presents as pain restricting a deep plie, often accompanied by dorsal soft tissue swelling and bony spurs at the front of the joint. Conversely, posterior impingement restricts the foot from dropping into plantar flexion, causing pain when the dancer works on demi-point or full point, typically involving structures like the os trigonum. When conservative management fails, surgery is an option. Whether using an endoscopic, medial, or lateral approach to remove the impingement, expectations must be managed. The dancer will spend roughly 4 weeks in a protective boot, followed by a mandatory 4 months of systematic, targeted physical rehabilitation. This process cannot be rushed. Looking at the biomechanics of point work, proper alignment runs in a perfectly straight line from the tibia down through the talus and into the midfoot. Inside the shoe, the structure dictates where the foot can move and how pressure is distributed. Dangerous fixes. Unfortunately, when dancers lack that required range, they can resort to dangerous fixes. Jamming feet under a piano or a couch to force plantar flexion is a terrible idea. It does not create functional flexibility. It creates severe pain, capsular damage, and soft tissue inflammation. We must never allow forced trauma to substitute for proper technique and conditioning. In conclusion, we must prioritize function over scans. A dancer with 10 years of proper classical training has built incredibly strong, resilient feet. Our job is to focus on functional rehabilitation and strength, not to chase after every anomaly seen on an MRI. Thank you.